Hi, everyone. Welcome to today's LACNETS webinar. I'm Lindsay Judovine, the Director of Communications for LACNETS.
And I'm Lisa Yen, the Director of Programs and Outreach.
Before we get started, I'd like to take a second to thank Rich at TVP Live for making today's webinar and high-quality production possible. We'd also like to thank our supporters, Ipsen, Advanced Accelerator Applications, Novartis, and Tercera Therapeutics. Before I pass it off to Lisa, I'd like to remind our viewers that these webinars are done for educational purposes only and do not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about your individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. And now I'll pass it off to you, Lisa.
Thank you, Lindsay. LACNETS is a program by GeneratePossibility.org, a registered nonprofit, and it stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society. Our mission is to provide education, advocacy, and support for all people impacted by this rare disease that used to be known as carcinoid, an old term meaning cancer-like. You'll often hear us say neuroendocrine cancer as a patient-friendly way to say the official medical term neuroendocrine neoplasm, which is an umbrella term for both neuroendocrine tumor, or NET, and neuroendocrine carcinoma, or NEC. We also say neuroendocrine cancer because we understand NET is a type of cancer and not cancer-like or benign as previously thought. While you often see Lindsay and I leading the meetings and programs, we are led by a team, which includes our Executive Director and Board Member, Kavya Velagapudi, and Board Member Donna Gavin, who is also the sister of LACNETS founder and Executive Director Emeritus, Giovanna Joyce Mbesi. Our board also includes Mary Dunleavy, who has been living and thriving with NET for over 17 years. We understand that those living with lung NET sometimes feel overlooked at conferences and meetings where much of the information often focuses on GI and pancreas NETs. We also feel like special populations such as lung NETs, parapheo, and high grade deserve more than just a short 15-minute segment in a conference because they are special populations and there's a lot to cover. That is why we are dedicating a monthly webinar to these special populations. This month, we are pleased to feature lung NETs. And I'm excited to introduce today's speaker, Dr. Sukhmani Padda, a distinguished thoracic medical oncologist who relocated last year from Northern California to Southern California to become the new Director of Thoracic Medical Oncology at Cedars-Sinai Medical Center in Los Angeles, California. In collaboration with multidisciplinary clinical experts and scientists, Dr. Padda's work focuses on expanding clinical trials and translational research in thoracic oncology. The ultimate goal of this research is to improve the outcomes of patients with thoracic malignancies. Dr. Padda has a particular interest in improving treatments for patients with rare thoracic tumors such as thymic malignancies and lung neuroendocrine tumors, and genomic subsets of lung cancer such as KRAS and EGFR-positive tumors. Dr. Padda also conducts research in tumor biomarkers to help determine optimal treatments for patients. She works with thoracic oncology experts around the country, leading and participating in clinical trials. Dr. Padda is a member of the North American Neuroendocrine Tumor Society, the Medical Professional Society for NETs, and the International Thymic Malignancy Interest Group. She has authored and co-authored dozens of papers and articles for peer-reviewed publications and is a peer reviewer for a number of prestigious cancer journals, including the Journal of Clinical Oncology and JAMA Oncology. Welcome, Dr. Padda. We're really excited to hear from you today.
Hi, I'm Dr. Sukhmani Padda. I'm Director of Thoracic Medical Oncology at Cedars-Sinai Medical Center. And today I'll be discussing with you lung neuroendocrine tumors and neuroendocrine carcinomas. It's my pleasure to be here today. So the objectives for this talk are the following. First, we're going to go through a pathologic classification overview of how we classify lung neuroendocrine tumors and lung neuroendocrine carcinomas. Then we're going to get into the details of molecular analyses of lung neuroendocrine tumors and carcinomas and the current state of research. And finally, we'll get into more practical treatment management, including indications for surgeries or other local therapies along with systemic treatments or medications. So let's first start with the pathologic classification overview. So this is how neuroendocrine tumors of the lung are classified. First, the pathologist looks under the microscope and confirms that indeed that they do see neuroendocrine morphology. And then it's time for grading the neuroendocrine tumors. So on the left, we have neuroendocrine tumors, which are low or intermediate grade. And on the right, we have neuroendocrine carcinomas, which are high grade. Under neuroendocrine tumors that are low or intermediate grade, this includes typical carcinoid and atypical carcinoid. And for neuroendocrine carcinomas, which are high grade, this includes small cell lung cancer and large cell neuroendocrine carcinoma. So what criteria do the pathologists use to classify lung neuroendocrine tumors and neuroendocrine carcinomas? So first, there's something called the mitotic count, which is a figure on the upper right. And so basically, when a cell is undergoing division to give rise to other cells, there's a mitotic figure that can be detected during this process. The other feature that they look at is for the presence or absence of necrosis, and that's the figure on the bottom right. So what necrosis is, it's a mechanism of cell death. And that can occur, for example, if a tumor is outgrowing its blood supply. So the pathologists are looking for these two things primarily. I know that Ki-67 is used in other neuroendocrine tumors to classify them, but for those of lung origin, it's only supportive. So let's look at a real world example. So this is a figure on the bottom left. On panel A, we can see a neuroendocrine tumor, and in the middle is that pink area, and that's what we call necrosis. And then as we get to a more microscopic level, which is panel B and panel C, you start to see these mitotic figures. Now, I'm not a pathologist, so that would be very difficult for me to tell. So that's why it's important for a pathologist who has experience in neuroendocrine tumors to be grading neuroendocrine tumors. So I do want to briefly touch on a unique entity that really only applies to patients with lung neuroendocrine tumors, which is called a mouthful, diffuse idiopathic pulmonary neuroendocrine hyperplasia, otherwise known as DIPNEC. And this can be classified under the microscope. And basically, there's a range of findings that the pathologist can see. They can see neuroendocrine cell hyperplasia, which are basically neuroendocrine cell overgrowths that are just sitting in the airway. Then there's these sort of baby tumors called tumorlets, which are less than 5 millimeters, which are starting to invade. And then there's also carcinoid tumors, which are larger than that 5 millimeter threshold. And as you can imagine, it may be difficult in a single sample, like a biopsy sample, for example, to see all of these different entities. So there is also a clinical definition for DIPNEC. Patients have often had symptoms for years to decades related to airway obstruction, whether that's cough, shortness of breath, wheezing. There's distinct findings on the imaging also indicating evidence of airway obstruction. So I wanted to make sure I mention this because I see a lot of these cases in my clinic, and we're starting to recognize this more as a field. So now we're going to move on to molecular analyses and talk about the current state of research in lung neuroendocrine tumors and neuroendocrine carcinomas, which has been quite phenomenal, and I'm going to show you some of that in the next few slides. So before we get into the details of these studies, I just want to do a quick timeout, quick review in terms of the basics of some of the words I'm going to use. First, what is DNA? DNA is a genetic code that's responsible for the development, the function of the cell, including cancer cells. RNA is a copy or transcription of the DNA, and it basically carries a message with instructions for the cell on how to make proteins. Now, what is molecular testing? So molecular testing is a test that analyzes genes, that's DNA, or other molecules, such as RNA. And an example of molecular testing that's commonly used in cancers in general is called next-generation sequencing. And finally, molecular testing can pick up mutations. What is a mutation? Mutation is a mistake in the DNA that this testing can detect. So what have molecular analyses have shown about lung neuroendocrine tumors and neuroendocrine carcinomas? So if we start with, for example, high-grade small cell lung cancer, it has a very different pattern of findings from the molecular level than typical or atypical lung carcinoid. So in small cell, we generally see inactivation or mutations of two tumor suppressor genes called P53 and RB1. This is almost universal, not 100%, but quite close. Given small cell lung cancer is also associated with tobacco exposure, there's also a molecular smoking signature that can be seen within small cell lung cancer. On the other hand, for the lower and intermediate grade typical and atypical carcinoid tumors, we see other findings. So one of them is MEN1 or menin1 gene mutations. And these are not always what we call germline mutations, meaning those mutations that can be passed from generation to generation, but a mutation that the tumor itself has just acquired on its own during its life cycle. So the mutation patterns and molecular findings of lung neuroendocrine tumors across the different grades are vastly different. I also want to talk about tumor mutation burden in lung neuroendocrine tumors and neuroendocrine carcinomas. So what I mean by that is how many mutations are in a tumor. So in lung carcinoid tumors, it tends to have low mutation rates, while high-grade tumors like large cell or small cell lung cancer have high mutation rates. And this has been published previously. So Dr. Birdslin at UCSF and myself presented some data at ASCO working with a molecular diagnostics company called Tempus to look at the rate of high tumor mutation burden in patients who have lung neuroendocrine tumors. And what was found is that the rates were higher in those high-grade tumors, small cell, large cell, upwards of 19%. But we still saw high tumor mutation burden in some of the carcinoid tumors at around 10%. One of the important findings that we also saw is that smoking drove some of this mutation rate in these tumors. So we can find a lot when we look beyond the surface of the microscope. And then there's large cell neuroendocrine carcinoma. My goodness, this is a very diverse disease. It can behave clinically, and it also looks different at a molecular level, DNA and RNA, if you look between different cases of large cell neuroendocrine cancer. So for example, there's been some research that's shown that there's two types. Type 1, which seems to behave more like non-small cell lung cancer from a genomic level, and non-small cell lung cancer is the most common kind of lung cancer we see in the clinics. But then there's type 2 large cell neuroendocrine, which acts more like high-grade small cell lung cancer, with those same inactivating tumor suppressor genes of P53 and RB1. So as we start to peel the layers of the onion, we see more nuances in how we're classifying these different neuroendocrine tumors across the grade. Then there's another question that's emerging. Is there a category in between atypical lung carcinoid, which is intermediate grade, and high-grade large cell neuroendocrine carcinoma? Or is there even such a thing as a supercarcinoid? So there's research on the left which demonstrated, looking at a very fancy gene signature, that there does seem to be this group of tumors that's kind of in between an atypical carcinoid and a high-grade large cell neuroendocrine carcinoma. And there was another study on the right which showed this potentially supercarcinoid. So when they look under the microscope, the pathology looks like a carcinoid tumor. But if you look at the molecular level, the DNA, the RNA, and also the clinical features, they seem to behave more like large cell neuroendocrine carcinoma. So you're getting the sense, the closer we look, there may be more overlap than we think, and there's more nuances. So a lot of research going on into the classification of neuroendocrine tumors beyond just what we know and what we do right now, which is the pathology. So in summary, I would say our diagnostics are imperfect in lung neuroendocrine tumors. I think one of the most challenging things for pathologists is distinguishing typical and atypical carcinoid. Right now, molecular testing is not routinely recommended in guidelines for lung neuroendocrine tumors, although that may evolve as we do more of this kind of research. We do tend to do molecular testing in large cell neuroendocrine cancer, because sometimes those behave more like our standard lung cancers, and we may find things that we're able to action on that impact our treatment decision making. And so I do have a question: if multi-omic analyses, these fancy molecular analyses, will be in the future. This was even another study called the Lung Nanomic Study that was presented at the World Conference on Lung Cancer in Vienna just a couple weeks ago, where they looked at the molecular data of over 250 cases of lung carcinoids. And even though we know right now there's only typical and atypical carcinoid, when they looked from the molecular level, they actually saw 4 clusters with different prognoses. So I just want to reassure you, there's a lot of research going on right now within these diseases, and eventually the hope is that they will eventually translate to treatments. All right, so now let's move on to some more practical treatment decisions around lung neuroendocrine tumors and neuroendocrine carcinomas, including indications for surgery. So what are the indications for surgery in lung nodes, specifically typical and atypical carcinoids? So the indication is if there's local disease that can be completely resected. That not only includes the tumor, but also the distribution of any lymph nodes that may be involved with the carcinoid tumor. There's also the patient side of things. Is a patient going to be able to tolerate undergoing a surgery? What's the functional status? What do the pulmonary function tests look like? Is the heart function good? And one of the critical things, I think, if feasible, is evaluation by a thoracic surgeon. There are different surgical approaches for lung neuroendocrine tumors: open, minimally invasive, sometimes using a robot, different types of surgical resections, whether you're removing an entire lobe or if you're removing part of a lobe. But one of the things that's very important is that the lymph nodes are systematically examined, either during the surgery or prior to the surgery. A surgery without examination of these lymph nodes is inadequate. So that's one of the things I wanted to emphasize. However, what if surgery is not an option? The tumor is not in a good location. We're worried about the patient being able to get through the surgery. So there is an alternative therapy called radiation, but it is important to know it has limited data for long-term outcomes. So there's something called stereotactic radiation that can be employed for small tumors that have no lymph nodes involved. And so this was a big national cancer study, kind of looking back at this database to see how patients did if they received a very focal type of radiation called stereotactic radiation, usually given in 5 days or less, or whether they received a more prolonged radiation course, which is over 5 days. And so what they found in these very early stage typical lung carcinoid tumors, there was a trend for improved survival for patients who received this very focused stereotactic radiation. So again, we prefer surgery if that is feasible from both a tumor perspective and also patient perspective. But radiation is something we can consider if the tumor is local and surgery is not an option. The other potential way to tackle this issue, depending on the location of the tumor, is called endobronchial therapy. So on the right is a picture of a tumor that's sitting in the left-sided airway. That's imaging panel A, and then you can see actually in the bronchoscopic exam that there's a tumor sitting right there. And so there are different treatments that can be provided within the airway for these very central tumors: laser therapy, cryotherapy, argon plasma coagulation. But again, the data is relatively limited, and there's some concern that maybe you're not completely resecting every single microscopic cancer cell. That's when we're talking about margins. And so in the limited series that have been reported, there has been a limited local or distant recurrence rate. So again, this may be an option for a patient with a lung neuroendocrine tumor who cannot safely undergo a surgical resection. So this patient underwent cryotherapy, which is basically applying very, very cold to the tumor. And we can see that 2 years later, the airway still looks quite open and there's no recurrence of the tumor. So these are alternative local approaches we think of when surgery is not an option. What about in the higher grade lung neuroendocrine carcinomas? What are the role for surgery? So for large cell neuroendocrine carcinoma of the lung, it's the same criteria. Is there local disease that can be completely resected, and is a patient a surgical candidate? If the answer is yes, then the answer is surgery. And we know that about a quarter of patients will present with disease that's potentially resectable by surgery. The one difference is that generally for this higher grade neuroendocrine cancer of the lung, we are employing systemic therapy, usually platinum-based chemotherapy in the perioperative setting, usually after surgery. And sometimes we're even talking about off-label use of immunotherapy, just because treatments in this type of disease are really not well defined. If the tumor is locally advanced, still local, but can't resect it by surgery, you can still go after it quite aggressively with chemotherapy plus radiation. So what about small cell lung cancer? There's actually a very limited role for surgery. And the reason that is because this disease can be very aggressive, often presents with more advanced disease involvement of the lymph nodes. And so generally for limited stage patients, we are offering a combination of radiation chemotherapy. And so the scans on the right are demonstrating a radiation planning where the radiation oncologists are really trying to precisely target the tumors. So again, going after these tumors very aggressively with radiation and chemotherapy when they're not amenable to surgical resection. So finally, we'll move on to systemic treatments or medications that can be used for lung neuroendocrine tumors and neuroendocrine carcinomas. So what are the treatment options for patients with lung neuroendocrine tumors, typical, atypical lung carcinoid? So there are many targets. So the first target is the mTOR pathway, which is a pathway in cancer that can be abnormal and cause the cancer cell to grow, divide, metastasize. And so everolimus is a drug that targets this pathway. In fact, it is the only FDA-approved therapy for patients with carcinoid tumors of the lung. The other target is somatostatin receptor, which is a protein that tends to sit on majority of patients' tumors with lung neuroendocrine tumors. And there are a couple different therapies that target the somatostatin receptor. One is something called somatostatin analog, octreotide, lanreotide. And the other is something called PRT, or peptide receptor radionuclide therapy, where you're selectively delivering radiation to somatostatin receptor expressing lung neuroendocrine tumors. And we'll talk a little bit more about that. There's also chemotherapy options that can be discussed. We'll talk about immunotherapy a little bit and what the data has shown in this disease. And potentially there's a role as well for vascular agents that impact the blood vessels. We also call those anti-angiogenic therapies. Not a lot of high-level data for that, but these are all the different targets we can consider in our toolbox when treating a lung neuroendocrine tumor. So first, let's start with the study of everolimus. This was a RADIANT-4 study. It looked at randomizing patients with well-differentiated neuroendocrine tumors, included patients, importantly, with lung neuroendocrine tumors to either everolimus or placebo. And so 90 patients with carcinoid tumors were included in this study. Majority of these patients had received prior therapy. But when we look at the progression-free survival, meaning the time the patient experienced disease-free without growth of tumor or development of new tumors, everolimus decreased that possibility by 50%. And that translated into a median progression-free survival, about 9 months for everolimus versus 3 months for placebo. The other figure on the right demonstrates that for patients with everolimus versus placebo, they tended to experience more tumor shrinkage. Now, tumor shrinkage at a very high depth level is not generally what we see with everolimus. It's more disease control, but overall slight tumor shrinkage, modest tumor shrinkage can be seen with this drug. So now moving on to the somatostatin receptor target. We know somatostatin receptor PETs, 68 gallium PET, 64 copper dotatate PET, are important for the diagnosis and treatment of lung NETs. So the reason for the diagnosis is because, for example, in this figure on the right, we can see that this patient has liver metastases that is demonstrated on the 68 gallium dotatate PET. It also tells us that this tumor has a presence of somatostatin receptor, and we could potentially do PRT, or that targeted radiation that takes advantage of the somatostatin receptor being present to selectively deliver the radiation. So what do we know about somatostatin analogs in lung NETs? I'm talking about octreotide, lanreotide. So we didn't really have very high-level data. We had these low evidence retrospective studies. The largest one contained almost 70 patients. Most patients received either octreotide or lanreotide in the first-line setting. And we can see that there was a good disease control rate, 80 to 90%, and the progression-free survival ranged anywhere from 11 to 30 months. So this is kind of the data we had for quite some time. There were, however, attempts to do clinical trials with somatostatin analogs specifically for patients with lung NETs. There's a very ambitious trial called the SPINET trial. It was a randomized phase 3 study to lanreotide versus placebo in patients who had somatostatin receptor positive lung neuroendocrine tumors. Unfortunately, because accrual was so slow to the study closed early to accrual, but they did report their results. And overall, there did seem to be a benefit of lanreotide over placebo, and maybe that benefit is more pronounced in patients who have typical carcinoid tumor rather than atypical carcinoid tumor. There was also a phase 2 LUNA trial with another somatostatin analog we don't as commonly use called pasireotide. This showed a disease control rate of 36% and a progression-free survival of 8 months. So together with the retrospective studies, with these smaller prospective phase 2 and 3 studies, we're getting the sense that we are seeing a benefit of somatostatin analogs such as octreotide and lanreotide in patients with carcinoid tumors. So now let's move on to peptide receptor radionuclide therapy in lung NETs. So you may have heard of Lutathera or lutetium-177 dotatate. That is a radiopharmaceutical that is approved for patients with gastroenteropancreatic neuroendocrine tumors. Unfortunately, in the trial that led to the approval for those group of tumors, patients with lung NETs were not included. So at this time, what we have is, again, these sort of lower evidence retrospective studies showing we treated X number of patients, and this is the response and progression-free survival that was observed. So the response rate across these different cohorts ranged from 10 to 30%, the progression-free survival from 11 to 30 months. So I do want to highlight there is a trial that's ongoing, the first prospective trial of PRT dedicated to patients with lung neuroendocrine tumors. This is a collaboration of 2 NCI cooperative groups, Alliance and ECOG Akron, and sites are slowly opening now across the country. So what is this study examining? So specifically, as I said, dedicated for patients with unresectable or metastatic lung neuroendocrine tumor. All patients will be evaluated for somatostatin receptor positive tumors using a dotatate PET scan. Patients have to have experienced progression within 12 months, but there is no limit on prior lines of therapy. So if all the other criteria is met, a patient could even potentially enroll on the study as front line. And so patients are randomized 1-to-1 to the investigational agent with his lutetium-177 dotatate, that's that PRT, versus the control, which is everolimus, which is our FDA-approved therapy for lung neuroendocrine tumors. And our primary endpoint that we're trying to see if there's a difference in progression-free survival. One of the things I want to highlight is that if patients do get randomized to the control arm of everolimus, we know that's going to be a very important treatment for patients with lung neuroendocrine tumors during their disease course if they have advanced disease. Patients can be considered for crossover to the investigational arm at the time of progression. So this trial does allow for crossover. So I wanted to highlight that here. And then just to highlight my co-chair, Dr. Thomas Hope, who's a nuclear medicine physician at UCSF, and I am the medical oncology co-chair representing ECOG Akron. So this is going to be a great study. Hopefully we get high-level evidence in terms of what therapy is best for our patients, because generally we want to sequence therapies in order of what's best. So this will be a very important study. And so if your physician or anybody is ever considering use of everolimus, just want to take a time out and also consider this study as well. Now let's move on to immunotherapy. So anyone who's been even following general media knows about immunotherapy because it's been such a revolution in many different cancer types. So what about lung neuroendocrine tumors? I would say overall the numbers are small. So it's hard to know precisely, although we do see responses in some patients. So I tried to pick out a couple of the studies where patients with lung neuroendocrine tumors were more represented in the patient population, and also those studies in which we have some dedicated efficacy data reported for this group of patients. So this was a combination study of immunotherapy, 2 different drugs, nivolumab plus ipilimumab. 29 patients in total of this study enrolled. This included both high-grade and low intermediate grade tumors. 39% were lung. And so when we look at an overall cohort, the response rate was 24%, progression-free survival was 5 months. If we look specifically at patients with atypical lung carcinoid, the response rate was 33%. And so that's what the figures on the right are showing. If you look at panel A, that blue box indicates patients who have obtained a response by our specific criteria. And each individual bar represents patient's tumor burden, and the blue bars are patients with atypical carcinoids. So those are the 3 responders that you can see there. On the B panel, we have what's called the swimmer's plot. So you have a sense of how long people have been able to remain on study or on study treatment. And at the very top are these 2 patients who responded with the atypical carcinoid of the lung, still on treatment at the last look here at about 108 weeks. So the response rate's overall low, but when the response is obtained, it can be prolonged. There was another study with a drug called spartalizumab. This is a PD-1 immunotherapy in lung neuroendocrine tumors. This is probably the largest dedicated study I've found. They had a thoracic cohort, which include lung and thymic neuroendocrine tumors. Majority, of course, were lung neuroendocrine tumors, and the majority of those were atypical carcinoid. Now, there's a biomarker that's associated with response to immunotherapy in certain cancer types, and that's called PD-L1. When we look at lung carcinoids, this tends to be expressed in a very low proportion of tumors, so just about 7%, for example, in this study. The response rate in this thoracic cohort was 17%, disease control rate was 73%, and then if you look at the overall progression-free survival of all the neuroendocrine tumors, that was about 4 months. So there are clearly a proportion of patients who can really get quite amazing benefit from this therapy. It's just a matter of how to select the patients who are going to be able to obtain that. So there's a lot of biomarker work that's going on in immunotherapy in cancer in general, because we're not so precise yet in being able to determine who is and who is not going to benefit. And so now let's turn our attention to lung neuroendocrine cancers and systemic therapy or medication options available to these patients. So for extensive stage small cell lung cancer, the therapy is very well defined in the frontline setting. It's a combination of a chemotherapy backbone, platinum etoposide, plus an immunotherapy that targets PD-L1, either atezolizumab or durvalumab. And the reason that is so set is because there were randomized phase 3 studies with both of these drugs incorporating immunotherapy that decreased the risk of death by 30% when they're combined with chemo versus chemotherapy alone. So that's a very set standard of care. In the second line setting, a little bit more challenging. There's a very old school chemotherapy called topotecan that's approved, has full approval. There's a newer drug called lurbinectedin, which has accelerated approval in this setting. And there's other chemotherapies that can be selected from. Advanced metastatic large cell neuroendocrine carcinoma of the lung is another story. Therapies really here are not well defined. So oftentimes we're borrowing from both the non-small cell lung cancer literature, which is the most common type of lung cancer we see, and also the high-grade neuroendocrine small cell lung cancer regimens, which are, as you can see above, more well-defined. And some of that it's really hard to know which one to choose. Sometimes you're looking at the biology, sometimes you're looking at the kinetics, sometimes you're looking at the genetics, as I mentioned way at the beginning, for that P53RB1 signature. So this is an area that needs further study. So in summary, everolimus is the only therapy approved for advanced lung neuroendocrine tumors. That's typical and atypical carcinoid. Clinical trials dedicated to patients with lung neuroendocrine tumors is critical. So we know that the therapies that we are using are the right therapies. And again, I just want to highlight this trial of lutetium-177 dotatate, which is a PRT versus everolimus, that's ongoing. And again, sites across the country are slowly opening. As for the high-grade neuroendocrine cancers, small cell lung cancer therapy is well-defined. However, the outcomes are still very, very poor, and it remains significant unmet need that we do better here. There is a lot of work that I'm going to talk about of further defining small cell using, again, molecular testing to look at different subsets where we may be able to tailor a treatment more precisely. So a lot of research going on in that field. And as I mentioned, large cell neuroendocrine carcinoma, the lung therapy is really not well defined. And this is another area that dedicated trials are really needed. So I thank you for your time and your kind attention.
Thank you, Dr. Padda, for this really informative presentation. It was really educational, and you covered a lot of ground. So I'm really excited to have you back for the Q&A.
Thanks, Lisa. I'm happy to be here with you and everyone in the audience.
Well, we have a lot of questions here, and we'll start first with some DIPNEC questions. So actually, as we get into the DIPNEC questions, if you can just remind us again what DIPNEC is. And the first question will be approximately how many people in the US and worldwide are currently diagnosed with DIPNEC?
Yeah, that's a great question. So just a reminder to the audience, a DIPNEC stands for many words put together. So I'm going to go through them with you. Diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. And there's a way to diagnose it under the microscope, and there's also a way to diagnose it clinically. And DIPNEC, I would say, has been under-recognized. If we look to the literature, perhaps only hundreds of cases have been reported. However, it is my feeling that as this spectrum of disease gets increasingly recognized, those numbers will rise, not because the incidence is rising of the disease, but because we are recognizing it more as a disease entity.
Yeah, we always need awareness for all of these things. So,
Exactly.
you know, there was a question around this and about whether it gets misdiagnosed, as NET does also. So this person in particular brings up that they are a non-smoker who has been diagnosed with mild emphysema based on lung function tests. Can this be related to DIPNEC? That person also had a right upper lobe lobectomy in 2015.
Yeah, so the diagnostic criteria for DIPNEC is really evolving. So if the pathologic perspective looking under the microscope, generally what the pathologist will see in the setting of DIPNEC is multifocal neuroendocrine cell hyperplasia, or areas of neuroendocrine cell overgrowths, and or baby tumorlets, so tiny carcinoid tumorlets less than 5 millimeters. So that's a pathologic diagnosis. And like I said, I think as we learn more about this disease, our diagnostic criteria will also evolve. Then there's the clinical findings of DIPNEC. So often people will have symptoms of airway obstruction, cough, shortness of breath, wheezing, often for years or even decades, honestly, preceding the diagnosis. I've seen personal cases of new diagnoses where a patient has had symptoms ongoing literally for decades. So that, plus there's certain imaging characteristics on CT demonstrating airway obstruction as well. There's a finding called mosaic attenuation, for example, on CT that can be seen. So generally between the pathologic criteria and the clinical criteria, and if feasible, discussing within a multidisciplinary tumor board can render this diagnosis. It is true that many patients in the cohort studies that have been presented, including one from a outstanding oncology fellow, Dr. Thomas Sun, who I had the pleasure to work with at Stanford University, have shown that there are, this is a disease that's not associated with smoking history, so often occurs in patients who have never smoked. So in terms of the pulmonary function test, now that goes to another area of DIPNEC. Some of the pulmonary function test findings based on previous studies show true obstruction, others are normal, others show restriction, others are mixed. So it's kind of all over the place. So there's specific criteria that would need to be looked at to see if this particular emphysema diagnosis could be related to DIPNEC. Great question.
Mm-hmm. Yeah. And I guess, what kind of criteria might that be? And this person, it might be a different person that's asking, do doctors confuse DIPNEC with COPD? So you're mentioning the shortness of cough, wheezing, all these things that sound similar.
Yeah, exactly. So absolutely, it can be confused for COPD. I've seen it confused for asthma based on, one, the symptoms that Lisa, you just described, and then of course, a proportion of those patients will also have obstruction demonstrated on their pulmonary function tests. They do a lot of specific measurements when a patient's going through a pulmonary function test and can determine if there's airflow obstruction that is present within the test. And so the diagnostic criteria, those are one that I outlined before, either pathologic, if you're seeing multifocal neuroendocrine cell hyperplasia or overgrowths or carcinoid tumorlets, and then clinically matching a patient's symptoms and also CT findings where you see evidence of airway obstruction such as mosaic attenuation, and sometimes even bilateral lung nodules, so tiny nodules in both lungs from a clinical perspective would be suggestive, because as you can imagine, it's sometimes hard to see the full spectrum of neuroendocrine cell hyperplasia, tumorlets, and like a tiny biopsy sample. Oftentimes, we're only seeing that if a patient has had some sort of surgical resection for a carcinoid tumor that may be associated or has had a surgical biopsy. So we can render this diagnosis clinically. In general, we want to do it within a tumor board just to make sure we're not missing anything else.
Okay. So if a patient or someone is wondering if maybe they're getting misdiagnosed based on symptoms alone, what kind of things might they need to ask their doctor for? And I heard you say biopsy, I heard you say tumor board, I heard you say CT scan. And is there a particular kind of CT scan or particular kind of biopsy they would need to get?
Yeah, that's a great question. So generally, DIPNEC is going to be the rarest cause of shortness of breath or obstruction on pulmonary function tests if we're looking at a general population. So I also don't want to give the impression that this is very prevalent. This is uncommon, this is rare, but it should be part of the list of differential diagnoses that the physicians thinking about if things aren't adding up, if things aren't making sense. So generally, a person who has these symptoms is going to be seeing a pulmonologist. That pulmonologist will generally take a history, a physical exam, often do pulmonary function tests, check the oxygen level, decide whether or not to pursue CT, and then depending on all of those things, is a biopsy needed? Is a multidisciplinary board discussion needed? So we also don't want to overuse diagnostic tests, especially if they're unnecessary, because sometimes we can go on sort of these wild goose chases for benign findings.
Yeah, yeah. Find a balance in all of this.
It's a balance, exactly, Lisa.
Yeah.
Absolutely.
So to clarify even further, if dip neck is detected, how likely will a person develop into a net over 5 millimeters? And if a person has lung net larger than 5 millimeters, how likely are they to have dip neck?
Yeah, those are great questions. So going back to this wonderful oncology fellow I worked with, Dr. Thomas Sun, we were also very interested in the growth kinetics of these pulmonary nodules. So in the Stanford cohort that was analyzed, we were able to follow a subset of patients' CTs looking back over time to understand the growth rate. And generally for these small, often tiny lung nodules, the growth rate is very slow. So looking across that population, it was like less than a millimeter per year. Now, this is not rigorous in terms of measuring growth kinetics of lung nodules, because the way to really do that in a systematic fashion is to take patients up front and prospectively follow their imaging at regular intervals, right? Because obviously, if patients are getting imaging at different intervals, the growth rates are going to be different. So we could potentially prospectively follow that over time and then follow the same nodules over time with an expert radiologist. But that's what we currently have based on the current literature. And I can tell you personally from my own clinical experience as well, patients have lung nodules that stay dormant for years and don't change. So that is definitely a real possibility with dip neck. As for the other question, if a person has lung net larger than 5 millimeters, how likely are they to have dip neck? So a lung neuroendocrine tumor or invasive lung carcinoid tumor is not necessarily associated with dip neck. So you have to have either these additional findings under pathology or these additional clinical findings that I previously described. In fact, probably most cases of lung carcinoid are not associated with dip neck.
Thank you for explaining that pretty clearly. So if someone has had dip neck with removal of several larger malignant tumors via lobectomy with lymph nodes clear, should a full body scan be done to confirm no other tumors are elsewhere?
Yeah, this is an area where data is really lacking on what kind of initial staging imaging tests we should be doing for our patients with a new diagnosis of dip neck. I particularly follow the guidelines, especially if the patient has had a lung carcinoid tumor. So I tend to do a CT chest with contrast and also image the liver, either CT abdomen triphasic contrast or MRI abdomen with contrast to make sure there's no distant disease in the liver. And then I also, at least one time in the disease course, will do a somatostatin receptor PET scan, such as 68 gallium PET. But we don't actually know how necessary it is to do all these tests in terms of whether you're going to find any additional findings outside of what you would just find on a quick CT. But great question. That's my practice. Other people may have different practices just because it's an area it's not well defined.
Yeah, more research is needed. So moving on to some other questions about lung in general, how common is it to have two types of lung cancer at the same time?
Yeah, it can happen. Anything is possible in terms of how frequently it happens. There was a publication that looked at second primary cancers for patients with neuroendocrine tumors overall, and found that the second primary cancer rate was about 8%. So it definitely can happen, which is why it's always important to examine these things under the microscope, because they may look different, they may be related to one another, or they may be two separate types of cancer.
Yeah, yeah. Thank you for that. And so you mentioned different types of, molecular, yeah, um, things that you've been working on. Should LungNet patients have genetic testing?
Yeah, it's a good question. So we know that a proportion of patients have lung neuroendocrine tumors associated with MEN1, which we can see from a somatic level, which just means that the tumor has the mutation present in it, but it's not in the germline, that you can't pass it on from generation to generation. But there is a small proportion, probably 5% or less, that have a germline mutation in MEN1. So I generally go through a family history. If there's a concern for either cancer syndromes related to MEN1 or just concerning cancer history across the family with such a diagnosis, I will refer to genetic testing, but don't necessarily refer all patients to genetic testing. But as you can imagine, we are continuing and going to continue to learn more about how cancers may be related to certain genetic predispositions that we don't know at this time, that we may learn in the future. So it's a really, really good question.
So I guess a follow-up to that, say someone was diagnosed 10 years ago, how often should they revisit the possibility of genetic testing? Because right now you may be just looking for MEN. What about, other tumor genetic markers that you might be looking for in the future?
Ooh, that's a tough question, because that's a question that applies not only to patients with lung neuroendocrine tumors, but across cancers. Because, like, even for example, as we think about lung cancer in general, the more common lung cancer, there's something called actionable molecular alterations that we can find within the tumor. And we know that as the diagnostic tests improve, as what is defined is actionable expands, meaning what you can do with that information in terms of strategizing treatment for a patient, it does come up even in that perspective. Like, should we rerun this tumor with this newer diagnostic assay that covers more genetic abnormalities to make sure we're not missing anything that's actionable? So I don't really have a good answer for you, Lisa, unfortunately, for that one. But I will say that many patients who have lung carcinoid tumors are going to be followed for 10 years, sometimes longer, for surveillance of their disease. So that's a question that you can go in to your doctor's visit with and say, hey, has there been any changes? Are there any additional testing I need to do, either from a diagnostic perspective or a genetic testing perspective? That's a bigger question. How do you integrate new information that's being learned when patients have already had testing, genetic testing and or tumor testing? It's really,
Yeah.
it's a great question.
So as people are living longer with this and things keep
Right.
changing and people like you are discovering new things, perhaps just
Right.
raising that question again and having
I
that
think that's
discussion.
great. I think that's great advice, Lisa. I think just asking your doctor if there's anything new in the field that would impact recommendations that you would have for your patient. Yes, maybe part of the
Yeah.
routine question is when you're going into that annual visit with your physician, or more frequently, if that's the case for you.
Yeah, yeah. Okay. Something to remember beyond just that initial diagnosis state to come back, to
Right.
circle back to with our net experts.
Yeah.
Um, and speaking of, information and gathering that information about my own disease, how do I know if my pathology is done correctly by someone familiar with LungNet? And how could I get a
Yeah.
pathology review by a pathologist who knows LungNet? I know you talked about this a little bit in the presentation, so perhaps this is where it's coming from.
Yeah, so that's another great question. So generally, when I'm looking at the pathology report, I want to see specific information that was used to grade the tumor as typical or atypical or high grade large cell or small cell. And generally things I'm looking for are that mitotic count. Is that listed in the pathology report? Is the presence or absence of necrosis commented on? Sometimes, even though it's not validated for grading lung neuroendocrine tumors specifically, you'll often see pathologists do like a Ki-67 proliferation rate to support the bucket that they've put this neuroendocrine neoplasm in. And so those are the things I look to see if the report has been comprehensive. Now, there may be a limitation in terms of like small biopsy samples or fine needle aspiration samples, because you just may have insufficient tissue to be able to do that level of analysis. I agree, it's sometimes hard to know. A lot of the bigger academic tertiary centers have pathologists who are focused in neuroendocrine neoplasms, such as, obviously I'm at Cedars, we have amazing neuroendocrine pathologists. So sometimes asking the pathologist to do a second opinion with one of these academic centers who may have more experience is something that can be considered.
Yeah, okay. The second opinions are always a good option. So this person said they're having an upper and lower scope, and they had a dotatate scan last November, and all was clear. 12 years post-NED, should they feel confident that they're okay?
Yeah, that's a really good question. So it depends on the precise diagnosis, but generally, for typical carcinoid tumors, even like the lowest grade tumors who have the slowest growth kinetics, we tend to follow those patients for at least a decade. If you look at our neuroendocrine tumor guidelines, like the collaboration between NANETS and COMNETS, we just say long term because we don't know the precise the precise number of years we have to follow someone out. But generally, the further you get away from the diagnosis, each year is, of course, more reassuring. And that the fact that there was a recent negative gallium scan is also reassuring. So, but of course, follow up with your physician if there's any areas of this particular case that I'm not familiar with, nuanced,
yeah, and I think
that I won't be able to comment on.
I think this person was a typical, from another comment, typical lung net. How do you know if a lung net is functional or non-functional?
Yeah, so this is another really good question. Compared to some of the patients with gastroenteropancreatic neuroendocrine tumors, patients with lung neuroendocrine tumors less frequently have associated functional syndrome, because we know that neuroendocrine cells are capable of secreting hormones and other peptides or proteins. So we do testing based on our clinical suspicion, probably because 10 to 13% of patients with lung neuroendocrine tumors will have an associated functional syndrome. So it is in fact the minority. But we're often assessing for signs and symptoms of carcinoid syndrome, such as flushing or diarrhea. And then there's also can be associated with Cushing's syndrome, where there's excess cortisol, and there's certain clinical features associated with that. So it's really sign and symptom-based directed testing. We're not generally testing everybody for hormonal or functional tumors, because it is more uncommon than it is common. And I will tell you that the tests are 24-hour urine collections, at least part of these tests. So it's not the most pleasant thing to do on your weekend. So if we don't have a clinical suspicion, we're generally not doing testing for hormones.
Okay.
But if there is, we definitely will.
And would you do the same serotonin or urine 5-HIAA?
Exactly.
Okay.
Exactly.
And so what is your strategy for symptom management for lung nets?
Yeah, that's a broad question because it depends on the symptom. So if it's a symptom related to functional syndrome, then you're obviously trying to maintain hormonal control, often with a somatostatin analog like octreotide or lanreotide. If it's symptoms related to like shortness of breath or cough, oftentimes we are in communication with our pulmonologist to examine the airways to make sure there's nothing hiding in the airways, because carcinoid tumors can really be quite central with endobronchial lesions. And so we want to make sure if shortness, breath, or cough is related to something like that, where we have local therapies that can help palliate some of those symptoms, like the laser ablation, the cryoablation, that we're not missing that. I hope that answered your question specifically about the symptoms that you were thinking about.
Yeah, so it depends on if it's like obstructive symptoms versus from the hormones or other things.
Right. Yeah. It can be a range of symptoms depending on the precise behavior of the tumor.
Yeah. And I'm also curious, of course, all people living with NETs might be joining support groups where they're hearing about all these other medications out there for management of symptoms. So which medications could they take to help manage their symptoms? Like would
Yeah.
Zermello and these other medications be useful for them?
Yeah, so it would be, that's a tough question to answer because the symptoms can be so specific. For shortness of breath and cough, for example, depending on the precise cause, if there's nothing within the airway, there's a variety of cough suppressants that can be given. Sometimes we work with our pulmonologists as well to see if there's any inhalers or inhaled steroid that they think might be beneficial. And then for the hormones, we're often also working with our endocrinologist to make sure we're optimizing the medication use for that particular hormonal syndrome. So these, when I'm evaluating a patient in clinic, I'm always trying to be as precise in my advice for that specific patient, knowing them as a person, getting to know them over time, knowing the details of their disease. So really always trying to also provide advice and sort of that precision approach. I know we talk about precision oncology as well, but we want to do that as well with managing people's symptoms and quality of life.
Mm-hmm. It really has to be individualized for each person.
That's right, exactly.
Yeah. Well, thank you for doing that. And you mentioned cryotherapy, and you may have already answered this question, but this question came up. Can cryotherapy be used in place of lobectomy to spare lung tissue in the case of a central G1 typical carcinoid after bronchoscopic tumor core removal?
Yeah, the field of interventional pulmonary is evolving very quickly in terms of what kind of therapies that they can give within the airway itself. Generally, as I mentioned in the talk, we want to offer surgical resection if that's feasible from a tumor perspective, and also feasible and acceptable in a patient perspective. So central tumors can be very challenging. Now, full disclaimer, I'm not a thoracic surgeon, but that's why I think it's so important for patients with lung carcinoid, especially these very central tumors, to see a board-certified thoracic surgeon, because they have, even for these central tumors, instead of, for example, removing the whole lung, there's another surgical resection called a sleeve lobectomy that can be feasible in some cases. So surgery is truly off the table, and we need a local control of a central tumor. Cryoablation is very reasonable. One of the things with cryoablation, because it's not a surgery, you're not able to examine the margins. You don't know if there may be some tiny microscopic carcinoid cells left behind that could cause problems in the future. So often patients who undergo this kind of therapy, in addition to imaging, they're also getting bronchoscopic surveillance. So similar to how people, for example, with polyps get colonoscopies for monitoring those, patients who have undergone these endobronchial ablation type therapies are often getting that as an additional surveillance tool that may not be used for all patients. But yes, it is an option, especially if surgery is not an option.
Yeah. And how often would people get bronchoscopic surveillance?
Yeah, that's another thing that's not precisely known. So generally, it's at least annual. in the pulmonologists that I collaborated with at Stanford and now at Cedars. But it's always a discussion, right? The further a patient gets away from the initial treatment and really hasn't had any signs of recurrence in that area, is there a way to space them out? We're always having those discussions and involving the patient in those discussions, because there is no just precise data to guide us on how frequently we need to do that.
Yeah, it's a evolving field for sure.
All these technologies, it's kind of incredible.
Yeah. Well, that's a perfect segue to this other question, because you were mentioning the lymph nodes. If the lymph nodes are not examined during surgery, would it be necessary to go back and examine them later?
Yeah, that's a good question. Generally not. If the lymph nodes were not examined, maybe there was a reason during the surgery that did not occur, whether that was a safety reason or it's hard to know precisely why. But generally, we're not going back and examining lymph nodes. There may be certain cases that are very nuanced where we may do that. But thereafter, relying on our imaging surveillance and monitoring that region, as you know, because the CT scans, they not only look at the lungs, but particularly if you give with contrast, you can see the lymph nodes quite well. So surveillance would follow this region on your standard imaging after surgery.
With a CT with contrast.
Exactly.
Okay, thank you. So moving to treatments, or other treatments, non-surgery treatments, should all LungNet patients be on somatostatin analogs? And what about after surgery if all the disease is removed?
Yeah, so maybe I can take the question first of somatostatin analogs after surgery if all the disease is removed. There is no role that we know of at this point in time for what we call post-operative or adjuvant somatostatin analog use. So if you've had a good surgery with negative margins, then generally there's no additional therapy that is given after that clinical scenario. So should all LungNet patients be on somatostatin analogs? Maybe not all. Generally, we're talking about somatostatin analogs if patients have a functional syndrome, such as a carcinoid syndrome. That would be, of course, a very good reason for a patient to be on a somatostatin analog. For patients with advanced disease that's not able to be resected by surgery, not all patients actually need to be on treatment. It really depends on the biology of the tumor, the location of the tumor, where are the distant metastatic sites, are any organs at risk, what are the disease kinetics. So there may be some patients who are just able to undergo active surveillance for a period of time before considering any therapy. And then also for somatostatin analogs, since its target is the somatostatin receptor, if we feel that a medical treatment is necessary for a patient with advanced or metastatic lung neuroendocrine tumor, oftentimes we want to see that their somatostatin receptor PET scan shows that the tumors are positive for somatostatin receptors, since this is a more targeted treatment. You don't feel as enthusiastic about using like octreotide or lanreotide if a patient's tumors are negative on a somatostatin receptor PET scan, such as 68 gallium dotatate PET. So not all, definitely not all lung neuroendocrine tumors. Again, we individualize a lot of these therapies, including some of the indications I just spoke about.
Thank you for that. And someone else had this question, and I know it might seem general, but when must one start treatment for LungNet?
Yeah, so if we're talking about advanced lung neuroendocrine tumors where it's not amenable to surgical resection, it's some of those things that I described. So what is the biology of the neuroendocrine tumor? What does that look like under the microscope? Do we have a sense of how it may behave based on the mitotic index, or if a Ki-67 has been performed, what that Ki-67 rate is? We're looking at the tumor burden. Are there any organs at risk? We know that neuroendocrine tumors of the lung can go to the liver. So if we're worried about the liver, we're often talking about initiating some sort of treatment. Sometimes it's a medical treatment, other times, specifically for the liver, we're working with our interventional radiology colleagues who also do liver-directed therapies, and even our surgeons in some instances. We're looking at the location of the tumor. For example, if the location is, even if there's low volume disease, if the location is sitting right in a central airway and is causing a lot of symptoms, obviously we need to treat that at least locally. And then if we have older scans, we're also looking at the growth kinetics. How quickly is this tumor changing? It's one thing if the disease is stable for a year plus versus if we see even moderate growth in a few months. Our wanting to start therapy is going to be higher when the disease kinetics are higher. So there's a lot of different elements of the disease that take into our decision making. And of course, because there's a variety of treatment options, local and medication, we're also doing shared treatment decision making with our patients, to see what would be acceptable to them. Is this worth it based on the risk benefit ratio that we're describing at this time? So it's you're taking in a lot of elements, even in such a basic question. It is a very important question of when to start treatment.
Yeah, a lot goes into that decision. And I love how you brought up that shared decision making as well, really weighing in what's important to the patient and their values.
Absolutely.
That's important. So with clinical trials, you mentioned some of them. How do I find clinical trials for lung, net, or neck? And for the clinical trials you mentioned, how do I find if there's a site near me?
Yeah, that's a great question. So one of the most trafficked sites is clinicaltrials.gov. And so that is a good place to start and put in search words such as lung neuroendocrine or lung carcinoid. That would be a place to start. Specifically for the collaboration with Alliance and ECOG Akron trial examining lutetium-177 dotatate. You can also find that on clinicaltrials.gov. And if you scroll to the bottom of the page, it'll tell you what locations are currently open. So Dr. Hope and I get a list of sites that are being activated once a month, but that also gets populated on clinicaltrials.gov. The final thing is if you have an academic center near you, since unfortunately many clinical trials are mostly conducted in academic or tertiary care centers, a second opinion with a physician there may also be useful. If they don't have a clinical trial at their site, maybe they have a colleague close by who may have a clinical trial. So there's a lot of discussion as well as how do we decentralize clinical trials so patients aren't having to travel and can receive clinical trials where they live. So there's a lot of discussion going on about that as well.
Yeah.
But those are some starting points you can take with you.
Yeah, so the second opinions, resources like you, and then the website, clinicaltrials.gov. Okay.
Yeah, and resources like you, Lisa.
Resources like me as well.
Yeah.
And you mentioned the PRT trial, and thank you for doing that because that's exciting and it's always helpful to open new trials. For that particular PRT LungNet trial, would those who have already been treated with everolimus be a candidate for this trial?
Yeah, so unfortunately, if a patient has already been treated with everolimus, they would not be eligible for this study because one of the control arm or the standard of care arm is everolimus. So for a patient who's looking for an alternative therapy, it would not be a right to randomize them to a treatment that they've already been exposed to. So that's why I had that little plug in the presentation. If your physician is ever recommending for you to go on to everolimus, to sort of do a timeout and see if this clinical trial could be an option for you. Is there a site that's active and open? And that was very important to us when we were designing the clinical trial, that patients were randomized to the investigational treatment, which is lutetium-177 dotatate, but then were in the control arm were randomized to an active treatment. So that was a rationale for our control arm. So just think about it. Anytime someone says everolimus, if this trial could be an option for you.
That's a really good point, just to have that pause there. And
Yeah.
I'm also curious, how long do you think the trial will be running, and how many patients are you enrolling in this trial?
Yeah, so I can't remember the precise predicted duration of the trial. It is anticipated to enroll over multiple years. We are targeting a little over 100 patients. So that's why really important for us to sort of increase awareness in these patient groups. So I'm just so delighted to be here with you today, and also ensuring that we're getting as many sites active around the country so patients aren't having to travel for this study. And I think the SPINET trial, which was that randomized phase 3 trial of lanreotide versus placebo for patients with lung neuroendocrine tumors, it was a very important study, but unfortunately the accrual rates were low, so that trial didn't fully accrue. So I think awareness of the trial from both physician, medical side of things is important, but even more important is ensuring that the patients know that this is a potential option for their treatment course.
Yeah. And as you're saying, the enrollment is so important, because without enrollment, without clinical trials and adequate enrollment in the data, we wouldn't be able to move forward with the treatments.
Yeah, and if I can just make a comment on that. So when we're designing a clinical trial, we pick a specific number of people we need to confidently answer our question. So if we don't enroll to that number, we don't know how confident we are in the answer that we receive from the trial. So accruing to the target population is very important to make sure that we feel confident in the answer we receive from the study, if that makes sense.
Yeah. So really, that's our way to add our voice and to move forward with progress, which is what we all want, progress.
Absolutely.
Yeah. Well, for this, more rare subset, so I have undifferentiated NET lung cancer for 1 year with disease progression. What hope and treatment is there for me?
Yeah, so that's a great question. So for poorly differentiated lung neuroendocrine cancers, those can be large cell or small cell. And that can be an important distinction because it could guide you to different trial options, because there's often dedicated small cell lung cancer trials, and less commonly, but they are out there, large cell neuroendocrine carcinoma trials. For small cell lung cancer, we're often giving patients a combination of chemo plus immunotherapy as their first treatment. And if there is cancer progression after that, if there's no trials, there's a variety of additional systemic medical treatments, chemotherapies, lurbinectedin, that can be tried. For large cell neuroendocrine carcinoma, it's a little bit more nuanced if there's not a clinical trial available, because sometimes we are borrowing from our non-small cell lung cancer literature in some instances for extrapolating treatment, and other times we're borrowing from our small cell lung cancer literature. But there is definitely in both of those types of poorly differentiated lung neuroendocrine carcinomas, there are definitely second line treatment options for both. And as I mentioned before, there's a lot of research going on in high-grade neuroendocrine cancers, really at a molecular level, trying to figure out, are there molecular subsets, biomarkers, where we can be more precise in delivering our therapy. so that we're not in an era where we're giving everyone the same treatment. So there are definitely treatments available.
Yeah, there is hope.
There's hope.
And
Yes.
this question comes up frequently. Does typical lung nets always recur? People say this cancer always comes back.
No, it does not always recur. In fact, for early stage typical lung carcinoid, majority do not come back.
That's hopeful. We're just going to take a couple more questions. And, this is an important question that comes up frequently. What's the best way to find the best specialist to manage dip neck? Most net specialists near me have most experience with GI net and not much pulmonary. Where can I find lung net doctors? And this is also, is applicable to all lung net, not just dip neck, of course, any lung net neck as well.
Yeah, absolutely. So my experiences with my GI neuroendocrine tumor colleagues that they have experience with dip neck and lung neuroendocrine tumors. They obviously have a different background because they are often interfacing with collaborators of GI tumors. So I actually find that most of my GI neuroendocrine tumor colleagues do have a pretty good experience with this. It is not an easy question. This is not an easy thing to find otherwise. There are also more thoracic medical oncologists who are specializing in lung neuroendocrine tumors and dip neck. So I'm a thoracic medical oncologist, which means I'm coming from the perspective of the lungs. So any tumor that can occur in the lungs, and then other rare tumors that can occur within the chest or thorax. So most of the cases that I'll be seeing in my clinic are the more common lung cancers. But I'm obviously also specialized in lung neuroendocrine tumors, and because of my specialty, I probably see a higher proportion than other thoracic medical oncologists. So I think if you start with someone who has experience, research interest in neuroendocrine tumors, that would be a good place to start. There are also some pulmonologists as well who are gaining interest in this disease, but I agree it's kind of hard to precisely pick out the people, especially in the vast world of Google. So it can be challenging.
Yeah. And how do people know if their specialty is dip neck or lung net?
You can ask them. Just ask them. Have you seen this before? If so, get a sense of how many cases they've seen, and a lot of people will tell you up front if they say, I don't have much experience in this, and they may refer you on to somebody else. But if you're wondering, just ask. Yeah.
Yeah. Yeah. Hey. And this question, and I didn't make this up, is Dr. Padda accepting new patients?
Yes, I am accepting new patients. It is important to note I'm only medically licensed in California, however. But yes, my clinics are open, and I'm happy to be involved in your care.
So that means that people need to come to California to see you.
That's right. That's right. If you're that's our current current licensure requirements, unfortunately. But yes, exactly. So if you're in the state of California, I can see you.
Do you do virtual visits as well?
I do virtual visits on a case-by-case basis. So I look at the records and try to decide what would be most beneficial. If I'm going to be able to give a full opinion virtually, or if there's going to be like an in-person examination, that would be very helpful for determining my advice. But definitely virtual visits. That's the one good thing that's occurred in the last couple years with regards to the allowances around the COVID-19 pandemic is the telehealth options, the virtual visits, and those are still currently in play. We haven't heard anything differently.
Yeah. In particular, as you mentioned, in the state of California. So that is
Exactly.
something that you could do. Well, thank you so much for your time. We went through many questions and got most of
Yes.
them answered, and I really appreciate this time you spent with us, and all that you do for your patients, and all the research that you do for us as well. We really look forward to more progress, more treatments, and more hope for the whole community.
Thanks so much, Lisa, for having me. Really appreciate it.
It's wonderful to have you. And now I'm going to send it back to Lindsay in the studio.
Thank you, Lisa and Dr. Pata. What an educational and information-packed Q&A session. Be sure you're following LACNETS on social media. We're on Facebook, Twitter, Instagram. Stay up to date on upcoming webinars and net news. Now I'll pass it off to you, Lisa.
Thanks, Lindsay. We offer many programs and resources, including our weekly virtual NET support group, a dedicated monthly virtual caregiver-only support group, NET Vitals, a downloadable patient-physician communication tool to help you prepare for medical appointments, and health coaching available to NET patients or caregivers. We encourage you to go to our website, lacnets.org, to find out more information about our programs, view resources, read blogs, take NET quizzes, and much, much more. LACNETS has developed a couple tools to help patients and caregivers learn to speak NET. In 2018, we developed NET Vitals with the help of Dr. Dan Lee at City of Hope. NET Vitals is a patient-physician communication tool to help you prepare for your medical appointments by filling it out as a self-assessment tool to give you opportunity to look up some things before your appointments and highlight the questions you have for your NET experts. It also helps you organize all the vital information about your NET in one document. This year, we developed an abbreviated NET Intro tool as a way for you to share your NET history with someone who needs to understand the key information about your disease in 2 sentences. NET Intro includes the first page of NET Vitals, and it's useful in, for example, our weekly support group, or when we're talking to NET experts, to be able to quickly summarize the essentials of our NET cancer in 2 sentences. So instead of taking 15 minutes to tell your story, you can bottom line these key pieces of information they need to know about your disease and then move on to ask your critical questions. It also, in our support group, allows us to be more efficient in our introductions to allow more time for networking. Go to our website for detailed instructions on how to build your NET intro. We've created a printable wallet-sized card that you can fill out and carry with you and have handy, and then you can pull it out to read your 2-sentence NET intro to your NET providers or practice in your support groups. We want to give a special thanks to our weekly support group whose input and feedback were valuable in developing the NET intro tool. NET intro is also available in our website in Spanish, thanks to Michelle de Quevedo from NETS Mexico, who has graciously translated the information. Did you know that LACNETS has a podcast featuring NET experts who answer the top 10 questions in their field? We release 1 episode every month, and we hope you'll take a listen. Thanks again to our special guest for today, Dr. Pata. We are grateful for all you do for the NET cancer community, and in particular, your dedication to research and clinical trials for lung NETs. Thank you again to Rich at TVP Live and for all of you for joining us today. Goodbye and see you next month.